Bismillah ar-Rahman ar-Rahim. Good evening, ladies and gentlemen. I am Ammar Abu Zuhaira, family medicine consultant, and I will be moderating this event. I would like to welcome you all in this webinar in celebration of the World Hypertension Day 2020. As you know, the slogan of this year is measure your blood pressure, control it, and live longer. It's my pleasure to introduce the first speaker, Dr. Tawfiq Al-Bassam. He's a consultant, internal medicine and clinical hypertension specialist from Medical Research Center in Jeddah. He's also a board member of SHAMS. He will be talking about COVID-19 and hypertension. The floor is yours, Dr. Tawfiq. Dr. Tawfiq, can you kindly share your slides and unmute your mic?
I'm sharing my slide. Do you see my slide now?
Not yet.
Now? Now?
No, still not yet.
Okay. Just give me 1 second, please. Now, do you see them now?
Yeah.
Okay. Bismillah ar-Rahman ar-Rahim. Wassalatu wassalamu ala Sayyidina Muhammad Ashraf al-Anbiya wa Khatam al-Mursaleen. I'm very happy to be part of the celebration day for the World Hypertension Day. I'm asked to talk about this topic, COVID-19 and hypertension, with a special focus on RAS blockers. I have nothing to declare. The objective of my presentation is introduction to COVID-19 pandemic, role of renin-angiotensin system and system blockers, hypertension status, and then conclusion. This is the COVID-19 virus that caused all the problem with the spikes protein. It all started in Wuhan, China in December 2019, where a pandemic outbreak caused by SARS coronavirus quickly spread to the Middle East, India, Europe, US, and South America. Now, this is WHO. As of yesterday, the numbers at a glance confirmed cases almost 40 million worldwide. Confirmed death more than 1 million worldwide. Countries, territories affected 235. That is really big number. Now, pathophysiology, we don't go into details, but usually there is a viral invasion stage, which uses the ACE2 receptors on the surface of the pneumocytes. There will be hyperinflammatory stage and immune system dysregulation, followed by hypercoagulation. Basically, also we have endothelial dysfunction in COVID-19, plays very important role both in the lungs and in the heart. Again, when we had this pandemic, we had really a problem with the community service to other branches like hypertension, diabetes, all were disrupted at the beginning of the crisis. We had a problem with that. Now, what is the link between the RAS system and COVID-19? Basically, the RAS system, we have the classical RAS pathway, which we all know, worked by ACE receptors, by the ACE enzyme, which changes angiotensin 1 to 2, which then acts on receptors, causing all the problems we have. We also have the counter-regulatory RAS pathway, which is actually activated by ACE2 enzyme, which is different from ACE enzyme, but it acts on a different pathway, leading to different peptides, forming angiotensin 1-7 or angiotensin 1-9, and acting on its own receptors, MAS receptors, or other receptors, angiotensin II receptors. You put them face by face, compare them. Classical system, the enzyme is ACE, whereas the counter-regulatory system, the enzyme is ACE2. Angiotensin II is the final product here, where here the final product is angiotensin 1-7 and angiotensin 1-9. The receptors here is angiotensin II receptor 1, whereas the receptors here is MAS receptors and angiotensin II receptors 2. Now the effect here, inhibit NO synthesis, cause oxidative stress, vasoconstriction, stimulate inflammation and immunological reaction. Here it does the opposite. Now ACE2, we just got really a big look at ACE2 within the crisis. Now ACE2 receptors at the surface of the pneumocystis type 2 cells, which the virus use an antibody inside the cell. In other words, the virus located these receptors on the surface of the endothelium, on the pneumocystis type 2, and sort of use them to enter the cell. And once it enters the cells, it uses the cell's machinery, including translation, transcription, to make its own protein and to put its own viruses, which bud out of the cells and cause more infection. Now, what is the clinical implication of all that? We had a problem with the antihypertension medication that might influence the severity. The first report, they were concerned that RAS blockers, including ACE inhibitors and ARBs, increase the risk of SARS-CoV-2 infection and more severe infection due to upregulation of ACE2. Those patients using RAS blocker are at increased risk of having the COVID-19 disease and a severe type of the disease. Now, these are the first information that was released at the beginning of the crisis. And what this was based on the following. Just look at the upper part of the slide. What happens that when you use ACE inhibitors or IRB, you increase the number of ACE2 receptors, you upregulate them, and therefore you allow the virus to go in more into the cell and cause more damage. That was the theory behind this, and this is what happened. However, these early reports quickly picked up by the press, social media, very fast, and were publicized. There were fear and trust among patients was created. At the same time, experts realized that they criticized these reports for many reasons. Part of it, they were mainly on animals. Part of it, they were small studies. And part of it, there were no sort of confounders found that explains their results. So what they did, all the society at that time, at the early stage, they decided to make a statement telling that people that continuing using angiotensin converting enzyme inhibitors and angiotensin receptor blockers in hypertensive patients until the new evidence arises in the future to the contrary. The reports showing the harmful effects of RAS inhibitors are not founded. Stopping or switching to other medication may be harmful, and there are still ongoing trials already on the way and will provide an answer to this debate. So this is the statement released by all the society, sort of to put everything back to perspective from the doctor's point of view, from the patient point of view. Now, what happened during this also time, we had another report. Now, the RAS blockers here may be beneficial. And what this happens, if you look at the downside of the slide, what happens is that when you have an ACE inhibitor on IRB, what they do, they stimulate the ACE2 enzyme, and that cause more angiotensin 1-7, which will act on its MAS receptors, causing vasodilatation, inhibiting vasoconstriction, inhibiting fibrosis, inhibiting inflammation. So actually, now the RAS blockers probably are beneficial. And then they cited the following. We had a lot of papers coming that shows benefit or at least no harm. I chose to use some of them, not all of them. This is the first one in circulation research, where they studied the association for inpatient use of angiotensin converting enzyme inhibitors and angiotensin receptor blockers with mortality among patients with hypertension hospitalized with COVID-19. That's what they did. And they concluded that hospitalized inpatient use of RAS blockers was associated with lower risk of all-cause mortality. So in another way, they were beneficial. Looking at it on a different way, these are the groups who were on ACE and ARB, and these are the groups who were none on ACE and ARB. The mortality rate here was 9.8%. The mortality here is 3.7%. So that's a good news. That means that the RAS blockers are beneficial. They decrease mortality. Then we start to have a load of articles, papers, favoring the use of RAS blockers. I will not mention all of them. I'll just mention the important one. This is Mahra, really a good article released in the New England Journal of Medicine, entitled Cardiovascular Disease, Drug Therapy and Mortality and COVID-19, stating the same thing. Now, Mancia in Italy did a really good study on renin-angiotensin-aldosterone system blockers and the risk of COVID-19. And again, the result, there was no effect of harm. And then we had Reynolds. We had a very good article in the New England Journal of Medicine, which compared renin-angiotensin-aldosterone system inhibitor and the risk of COVID-19, and again showed there is no harm. The latest trial was the BRACE Corona trial, released just, I think, for 8 weeks ago. And what they did in this trial, it's a multi-center phase 4 randomized clinical trial. They randomized about 660 patients, 2 groups. First group, they temporarily suspended ACE/ARB treatment for 30 days. The other group, they continued to use ACE/ARB treatment without stopping them for 1 month. The primary outcome was days alive and out of the hospital at 30 days. What did they find? That if you continue ACE/ARB or if you suspend ACE/ARB, there is no difference. So in reality, the presence of ACE/ARB caused no harm at all for this patient admitted to the hospital. So they concluded that BRACE Corona provides randomized trial evidence showing that suspending ACE/ARB therapy for 30 days did not impact the number of days alive and out of the hospital, which is good news. However, there was a limitation for this trial. The total number involved was small. The age was middle-aged population, whereas most people admitted was elderly. Distribution of RAS blocker was uneven. Few used ACE inhibitors, majority used ARB as a drug. Now we come to the second part of our presentation, hypertension role. Since the beginning of the pandemic, we had a lot of studies that suggest the risk factors causing COVID is hypertension, obesity, chronic lung disease, diabetes, and cardiovascular disease. So hypertension was always there. And the initial report showed high rates of hypertension among hospitalized COVID-19 patients. A New York report, 56% of hospitalized COVID patients had hypertension. It's the same in case series. Now, I just wanted to show you the New York report, which is a really large number of patients. What I'd like to point to that cardiovascular disease, among them hypertension, was prevalent in 56.6%, the highest ever among risk factors, followed by obesity and diabetes. This confirms that hypertension is there. However, many of the hospitalized COVID-19 patients were older with multiple comorbidities. Therefore, some experts still debate a causal role with an association. They suggest that probably hypertension is present because the elderly, most of them, they already have high blood pressure before COVID-19. So there is no actually a cause directly related to hypertension causing the illness or making the illness worse. However, hypertension remains the greatest modifiable risk factor for atherosclerotic cardiovascular disease. This has not changed at all. We know now that uncontrolled, under-untreated hypertension is more important here since it is a risk factor for getting infected and a severe form of infection with COVID-19. Now, this is just an illustration showing that those hypertension without medication or no hypertension, the red diameter here, rectangle, indicates mortality. Somebody with hypertension, mortality gets high. If he is not medication, even the mortality is higher. So he's at risk if not treated, compared to somebody with no hypertension. Now, realizing all this, it is important to focus on treatment of hypertension in the era of COVID-19. We need to focus on both items, lifestyle modification and medication to reach blood pressure target. We need to follow up with the healthcare provider, arranging an appointment or via telehealth if possible. We need to focus on medication adherence if it's a problem in reaching blood pressure target. It is also important to keep a supply of medication for a period about 2 or 3 months. Now, these are general guidelines for all hypertension patients. We need to focus on them and do whatever it takes to get them on this aspect, controlled hypertension. I'd like to just mention 2 points about hypertension and 2 slides on hypertension in the elderly. First of all, many elderly fearful of COVID-19 stopped by themselves follow-up of routine medical care. They were afraid to go to the hospitals. They may have reduced their intake of medication or stopped taking pills altogether. They should be contacted to encourage to reschedule visit if blood pressure is not controlled. We can use telehealth contact. It's very helpful to reach patients who cannot reach the hospital. This is an important point. We need to go look for them rather than wait for them to come to the hospital. Now, for the elderly, we need to emphasize on maintaining nutrition, hydration, and daily exercise. We need to focus on continuing daily intake of medications. We need to advise having medication supply for a period about 2 to 3 months is advisable. We need the family members' involvement is essential for the elderly because this is a time the family members should focus on the elderly and they help them with whatever it takes, especially when we are talking of telehealth, when they just talk to the doctor by telephone or by video and so on. Influenza and pneumococcal vaccine is advised. Now I reach to conclusions. I have just 3 more slides. Conclusion number 1. Controlling hypertension was important before COVID-19 pan-epidemic. However, now with COVID-19, it is even more important to control it to protect the health of the individual. The emphasis on continuation of both non-pharmacological and pharmacological therapy is vital. We should enlist the help and support via clinic visit if needed or via telehealth contact as needed. The initial observation studies was suggested that blocker use will put user at risk are unfounded. The RAS blockers are safe to use. We should avoid stopping them or change in medication unless approved by the healthcare provider. Also, we should encourage all hypertensive patients use the other preventive devices, wear masks whenever go outside, gloves as needed, avoid crowds, keep a distance, safe distance, frequent hand washing. These are the things we should put in their minds of all hypertension patients, especially if they go out frequently. And my last slide is all healthcare workers should stand up to the challenge of COVID-19 infections. We should not allow COVID-19 pan-epidemic to hurt our patients. We need to fight back. We can win this battle and keep our patients healthy and safe with good planning, teamwork, and dedicated efforts from all sectors. Thank you for listening.
Thank you, for your nice presentation, for sticking to the time. I have 2 notifications. First, please write your name if not already done. And second, if you have questions, please write them in the chat and we will discuss them at the end of the speeches. It's my honor to introduce the second speaker, Dr. Abdul Hamid Hassan. He's a consultant family physician. in International Medical Center, Jeddah. He is also a board member of Shams. He will talk to us about early identification of patients with hypertension and timely and proper diagnosis of hypertensive patients. The floor is yours, Dr. Abdel Hamid.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Walhamdulillah bil alameen. Wassalatu wassalamu ala sayyid al-mursaleen. I will start with early identification. By early identification, I mean proper diagnosis in the time where the disease is there, not waiting for many years before labeling the patient with hypertension. Before that, I will show you some recent updates related to the early identification, because this will impact the control of patients with hypertension. This paper published just a few weeks ago in Hypertension, and it showed only 16% of hypertensive patients are controlled. Out of 1.5 million patients with hypertension in 92 countries, they are only 16% controlled. The second paper, this published from the Surgeon General in United States of America. This month, although with the whole problem of pandemic of COVID-19, still the Surgeon General insisted that control of hypertension is a national priority for healthcare system. And without identifying a hypertensive patient, we cannot control them. So identification is very important. Proper diagnosis is very important. And there is now a working group working in the state to try to improve the control of hypertension in America, although there is a pandemic of COVID-19. And this paper published in Circulation also this month, the association between the age of onset of hypertension and the cardiovascular diseases and the mortality. And it showed that hypertension was associated with higher risk of cardiovascular disease and higher risk of all-cause mortality, and the association is stronger with younger age of onset of hypertension. So diagnosing hypertension among younger adults is very critical, because it helps us to control them properly to reduce this increased risk of cardiovascular disease and all-cause mortality. The editorial of the same paper in the JACC, the same article, the editorial for it, this is the title of the editorial. Early onset hypertension is under-recognized, not diagnosed, under-treated, and underestimated the risk. We minimize the risk of patient, young adult with stage 1 hypertension, and we said this is a low-risk patient, no need to treat or treated minimally, and this all were discussed in this editorial. The editor of this paper said it is the first time to assess the relationship between age of hypertension onset and adverse outcomes. The reliability offered by this paper, because it is a large cohort size and a high average of cardiovascular death and mortality, almost 2,000 in each category. And he mentioned, although rates of hypertension awareness, treatment, and control are lower among younger compared with older adults, current guidelines did not recommend using age as a risk factor in the assessment. Up to date, the recommendations don't yet emphasize the importance of adequately treating young adult patients, and this is a very important point. Many guidelines said don't treat, don't prescribe. There is a threshold up to 160 to start the drug treatment for young adult. This is not good. And that's why in our next international conference in November in IMC, we have a special lecture about this, managing young adult low-risk stage 1 hypertensive patients. Further, the editor said guidelines should include revision of the treatment approach for patients with early onset hypertension, giving the importance of lifetime risk, not 10 years risk. This is a very bad way to calculate the risk for the young adult. We should calculate the risk for young adult for 30 years. What's called the lifetime risk, not 10 years risk. The last paper related also to my presentation in Saudi Arabia, it is the prevalence and the clinical correlates of ambulatory blood pressure phenotypes in a Saudi hypertensive populations. This published again recently in the Journal of Clinical Hypertension. The authors concluded that office blood pressure overestimated the control rate, so it gives us a false impression that our patients are controlled compared with ambulatory blood pressure measurement. Look for the difference from 50% to 10%. Huge difference, highly statistically significant. And they emphasize that this study shows that 1 in 3 Saudi patients will be managed inappropriately if office blood pressure alone was relied upon for the management of hypertension. This is the emphasis of my next slides about ambulatory blood pressure monitoring and home blood pressure monitoring. Now let us go to the presentation. The first is the guidelines 9 years ago. Nice guidelines, nice, very cost-oriented, very evidence-based, very conservative. What they said to diagnose hypertension, early identification. They said if the blood pressure is above 140/90, directly go to ambulatory or home blood pressure measurement to confirm the diagnosis. No way in NICE guidelines to diagnose hypertension in the clinic. Once it is above this level, whether in the clinic, in the street, in the pharmacy, in the shopping mall, anywhere, go directly to home or ambulatory blood pressure measurement. This is the American Heart Association, American College of Cardiology 2017. Again, they said out-of-office blood pressure measurements are recommended to confirm the diagnosis of hypertension and to titrate treatment. So follow up, increasing the medication, reducing the medication, keeping the same medication, diagnosing everything should be based out of the office. Office blood pressure measurement is just done just to complete the picture of the medicine, of the hospital, of the clinic. But all the decisions, whether to diagnose, to start a team, to continue, it should be based on out of office. This is Shams guidelines. Again, our recommendation for diagnosing hypertension, similar with some modification with the Canadian guidelines. Again, we said out of office measurement, ambulatory or home. If these are not available, we may refer to office diagnosis with over 3 to 5 visits to confirm the diagnosis of hypertension. So the identification should be based on out of office measurement. This is the European guidelines 2 years ago. Again, they said if the blood pressure is 140/90, repeated visits, 5 measurements, 5 visits, or go for out of office measurement, ambulatory or home blood pressure measurement. This is nice. The most recent guidelines last year, they said the same. If the blood pressure measured in the clinic is 140/90, repeat for a second or the third. If the clinic, the 3 measurement in the same visit above 140/90, go for ambulatory blood pressure to confirm the diagnosis. If ambulatory is not available, go for home blood pressure. So confirmation of the diagnosis should be based on ambulatory or home blood pressure measurements. This is nice, repeating after 8 years, they still consistent with the out of office to diagnose, to identify, to control, to manage all patients with hypertension. This is the Canadian. What is still important? It was important before, until 2020 still important. The diagnosis of hypertension should be based on out of office measurements. And the second point, in the office, use the automated office machine. No more mercury machine, no more auscultatory measurement. It should be electronic machine, validated, calibrated, everything, but it should be an automated machine. This is the algorithm, the same as ours, but they didn't put the office in no possibility to diagnose in the clinic. It should be ambulatory or home blood pressure measurement. This is the most recent guidelines, International Society of Hypertension. They have 2 versions, one for low economic countries and one for high economic societies. And this is just to show you My presentation will not talk about how to measure the blood pressure. The blood pressure measurement is another workshop, but I'm just showing you that they put the electronic machine, not a mercury machine. It is the electronic machine to measure blood pressure. Again, in the low socioeconomic countries, they said if it is 130 to 160, if possible, please confirm with out-of-office blood pressure measurements. And they said, if possible and the available diagnosis should be confirmed by out of office. Confirmation with out of office for most treatment decision, to keep the same treatment, to increase the treatment, to reduce the treatment, to do anything, it should be based on out of office, not on the one single measurement over 3 months in the clinic. It should be repeated measurement whether ambulatory or home. The diagnosis, of course, if it is 180 over 110, it is diagnosed from first time, no need to confirm, no need to take any time and start the treatment at once. This is the low socioeconomic classes by the International Society of Hypertension. Again, remeasured in the office 3 visits to confirm the diagnosis, but better is to go for ambulatory blood pressure measurement or home blood pressure measurement. This is the high socioeconomic countries in the International Society of Hypertension. Again, they said go for confirmed by home or ambulatory blood pressure measurement.
Dr. Abdulhamid, I cannot hear your voice. Kindly unmute your mic. Dr. Abdulhamid. Dr. Abdulhamid, I cannot hear you. Dr. Badr, is it my problem or?
It is Dr. Abdulhamid's problem. Dr. Abdulhamid, إذا ممكن unmute the mic. دكتور عبد الحميد إذا ممكن تشغيل الصوت من عندك. دكتور عبد الحميد يبدو أن الصوت قفل عندك، إذا ممكن تشغيله.
كده كويس؟
اوكي.
تفضل.
تفضل.
يبدو لو تعيد آخر 2 slides أكون شكر مع الشكر.
سوي شوي إلى السلايدز بعد. You stop sharing your slide. Kindly share your slide and do full screen show. دكتور عبد الحميد لسه معانا؟
معاك.
اوكي. سوي شير سلايدز. اوكي الحين ظهرت السلايد. سوي فول سكرين. يلا تفضل.
So I will continue. This is still the International Society of Hypertension. They said the diagnosis should be confirmed by out of the office. And any treatment decision, again, should be in the based on the out of office measurements, home or ambulatory. This is the last consensus from the American Heart Association and the Medical Association just a few weeks ago, and they said home blood pressure measurements or out of office is very important, very reliable, and should be the basis for all decisions in the management, starting from diagnosing and continuing treatment for patient with hypertension. And this is the recent recommendation. We got it in the private sector from مجلس الضمان الصحي التعاوني, and it is in conjunction with the Saudi Society of Family and Community Medicine. They said out of office measurement, home or ambulatory, should be requested if the blood pressure is from 130 to 85 and between 180 to 110. That's why in our hospital, most of the patients with this reading in between, for the first time, we order for them ambulatory blood pressure measurement to confirm the diagnosis, or issue for them is home blood pressure monitoring. And it is covered by insurance based on مجلس الضمان الصحي التعاوني in the Kingdom of Saudi Arabia. This is a very important step in the management of hypertension in the private sector, confirming that insurance companies will provide all patients with hypertension with a monitor at home. Exactly like the patient with diabetes, we offer them a glucometer at home. These are the final slide, the readings. What in the office known as 140/90, it at home equals to 135/85, daytime ambulatory 135/85, nighttime 120/70, and the 24 hours 130/80. So early diagnosis confirmed by home or ambulatory is a must to be able to identify patients, then we can reach the best control for them. Thank you.
Thank you, Dr. Abdelhamid, for updating our knowledge about the importance of early diagnosis of hypertension. Let's move to the last talk of tonight's webinar. Our last speaker is Dr. Hussam Junaid. He's a consultant internal medicine, section head of polyclinics at King Faisal Specialist Hospital and Research Center in Riyadh. He's also a board member of SHAMS. He will talk to us about the review of pharmacologic and non-pharmacologic management of hypertension. The floor is yours, Dr. Hussam.
Thank you, Ammar. I don't know, do you see my slides?
Yes, kindly make them full screen.
Okay. So, Assalamu alaikum wa rahmatullah. Good evening, everybody. Today, actually, my presentation is the last presentation. I'm going to talk briefly about the management of hypertension and non-pharmacologic management. So, as you heard, I mean, the blood pressure definition, actually, by many organizations, still go to more than 140/90 as grade 1 hypertension. The European are still going with 130 to 139/85 to 89 as high normal. And everybody agrees that the normal is less than 120/80. The American Heart Association, changed the definition since 2017 and made it as more than 130/80 as hypertension. And actually, many organizations are agreeing now that the goal of treatment, at least in many patients, especially high risk, should be less than 130/80, even though not everybody is agreeing that the blood pressure should be, the definition of hypertension is 130/80. They are still going by 140/90, but the goal of treatment in many patients, as we will see, should be less than 130/80. Of course, what determines the speed of treatment and also the goal of treatment and the choice is the presence of the cardiovascular risk factor, the choice of treatment, Other cardiovascular risk factors usually are like the cigarette smoking, obesity, physical inactivity, diabetes, the microalbuminuria, and the age and the family history, of course. So we usually, look at how many risk factors the patient has, and also the degree of the hypertension and the grade of the hypertension. The higher the grade and the more the risk factors, that means that the patient is more higher risk, and that means that we have to act more quickly and more aggressively in those patients. And we look also, when we decide the treatment, not only on the associated risk factors and the grade of the hypertension, but we look also at the target organ damage. And the target organ damage, we mean, of course, the vital organs, especially the heart, the brain, the kidney, the eye, and the peripheral arteries. So the management of the hypertension, we always say we start with a non-pharmacologic, which contains the lifestyle changes. Lifestyle changes, we always encourage the healthy lifestyle with everybody, especially those with chronic diseases like diabetes and hypertension. And lifestyle actually help to prevent and delay the onset of high blood pressure and reduce the risk factor. And it is always and should be always the first line of treatment, of course. The modification in lifestyle can also enhance the effect of antihypertensive treatment. So the cornerstone of the lifestyle is the diet, really. And the most important factor in diet is the low-salt diet. Low-salt diet is the cornerstone, actually, of any advice that we give to our patients. And in addition to that, of course, now we encourage consumption of, whole grains, the fruit, vegetables, the polyunsaturated fats, and dairy products, which is found in the DASH diet. And even the Mediterranean diet, there are many information regarding the Mediterranean diet and its importance in hypertension and other cardiovascular diseases. Reducing fine sugar, of course, also is playing more and more important role, and reducing the saturated fat and trans fats as well. Now, the vegetables which are high in nitrates, like the leafy vegetables, are also playing a role, and like the beetroot, and the other benefits also in nutrients and in food, which is rich in potassium. There is more emphasis now on potassium and magnesium, which could be found in avocado, nuts, seeds, and in legumes. Healthy drinks like the green tea, the pomegranate juice are also playing a role. And of course, in addition to diet, there is reducing weight and avoiding obesity. And there is also you have to be careful with non-proven like herbs or traditional medicines, which we don't know the safety of. Better to use the reliable and better to use more the natural, actually, food and the natural healthy food. So we have the diet, we have reducing the weight, avoiding obesity. Also, we have the exercise, of course, and smoking cessation. The exercise, of course, we always say that the minimum is 30 minutes for 5 days a week, which is 150 minutes. This is the minimum of moderate exercise that we encourage our patients who can do it. And even patients who cannot do it or who are like really sedentary or who have like handicapped, we encourage them to do, even in their like chairs, to do some exercises. Resistance exercises are also important in hypertension and other cardiovascular diseases. Reducing stress, increasing mindfulness, and reducing exposure to air pollution and cold temperature all play a role. So as a summary for lifestyle changes, this table summarizes most of the lifestyle which are warranted. The weight loss should be around. If you reduce your weight really, you will decrease your hypertension by -5 millimeters mercury in hypertensive patients. And DASH diet also will decrease it even more if you consume and if you stick to healthy diet. Reducing intake of dietary sodium, which we always recommend, as I mentioned, also it will decrease it by 5 to 6. We recommend less than 1,500 milligram per day, or at least 1,000 milligram per day reduction in most adults. I always tell my patients, don't add any salt to your cooked food, okay? Because the cooked food actually has, or I mean, any food has in its contents, I mean, some salts. So the sodium chloride, whatever its form, whether it's like milk sakhri or any kind of other kind of salt, it all has sodium chloride, and it should be actually decreased to the minimum. Whoever doesn't like the taste can add lemon or vinegar to change the taste. And of course, I mean, the ones who are healthy and would like to add a little to their dish, they can do it. Also increasing, as I mentioned, the intake of potassium now is playing more and more a role, and the physical activity, aerobic, dynamic, and isometric exercise. So the secret to living well longer is eating half, walking double, laughing trouble, and love without measure, of course. Now, in most patients, unfortunately, we fail in controlling the blood pressure by only doing the lifestyle changes. We, most of the time, need to start on medication. We look always for the drug, the ideal drug. The ideal drug actually should be evidence-based. It's better to be taken once a day, to be more convenient, and should be affordable and cost-effective. And also, it should be well tolerated with many, I mean, less and less side effects. And the benefits, I mean, of course, the evidence of benefits of using it should be widely actually accepted and proven. But does it really matter what kind of medication we use? What matters more actually is the blood pressure target, reaching the goal. Okay, of course, it matters if there are some indications, if there are some, as we will see, but I mean, reaching the goal is our most important target. In this old ALHAT, very well-known ALHAT study, all medications, when they reach the goal, they had the same outcome, whether it's calcium channel blocker, it's ACE inhibitor, or thiazide-like diuretics. And as I mentioned in the beginning, I mean, the speed of initiating medication and not waiting too long for the lifestyle really depends on individualization of the patient. If the patient has many risk factors, like this patient, more than 3 risk factors, or if they have end organ damage, for example, and if the degree of the hypertension, so the degree of the hypertension, the number of risk factors, and the presence or absence of end organ damage will tell us when to start really the medication and how fast. In this patient, for example, with the 3 risk factors here, and with grade 2 hypertension, according to the old definition of hypertension, usually, I mean, we start with medications right away. We don't wait like for weeks or months for the lifestyle. We start with both lifestyle and with blood pressure medication. Whereas in this patient, for example, with 1 to 2 risk factors and with grade 1 hypertension, we wait for a few weeks before starting medications, for example. Now, the American Heart Association, as I mentioned, they are more aggressive in the definition of hypertension and on the treatment, but they are always emphasizing the non-pharmacologic treatment really, and reassessing if the patient does not need or doesn't have a lot of risk factors. For those who have like really estimated risk factor more than 10%, then no, we don't wait for long. It's the same concept. We start the medications actually, and we reassess always after like 1 month if the patient is high risk, or after 3 to 6 months if the patient is at lower risk. And we need always to reach the blood pressure goal, or if we are not reaching, then we have to assess the adherence to therapy. We have to make sure that the patient is really compliant, and we optimize the treatment, and we consider the intensification of the therapy. We in SHAMS, in the last time we updated our guidelines, actually, we still went by the old definition of hypertension, less than 140/90. And actually, we mentioned only one category for 130/80 as a target blood pressure. I mean, I'm talking here about the target blood pressure or the goal. In patients with chronic kidney disease with the proteinuria, it should be less than 130/80. And this is based on evidence, of course. In other categories, mostly it's 140/90 as a target. But now we'll see that the International Hypertension, the International Society of Hypertension, and the European, I mean, Society of Hypertension both agree that actually in many patients, the target should be less than 135/85, especially in patients who are not very old and who have risk factors, like in this diagram in the 2018 update of the European guidelines. Now, in this table, actually, it summarizes the blood pressure goal for many organizations, including the American. Of course, the Americans always 130/80 is our goal. In the Canadians, especially with patients with chronic kidney disease or diabetes, our goal is 130/80. And in the European, this is before the latest update. In patients with high risk, it should be less than 130/85. Now, what medications we have? We have many medications, but we have the first-line treatment. The first-line treatment, and this table is from our SHAMS guidelines again. The first-line treatment is thiazide diuretics, calcium channel blockers, the non-dihydropyridine, the ACE inhibitors, ARBs. Any one of them is first-line treatment. But if there are other indications, other comorbidities, that will help us in choosing the medication. For example, in thiazide diuretics, it is preferred in patients with congestive heart failure, in elderly, and it is should be avoided, better to be avoided in patients with gout, hyponatremia, because it might cause them, and in patients with like sexually active male, it might lead to impotence. In pregnancy, of course, and dyslipidemia, it might make it worse. In loop diuretics, we give it in patients with congestive heart failure, for example. The other first-line treatment, like the calcium channel blockers, it is preferred in patients with angina, for example, actually, it should be avoided in patients with congestive heart failure or patients taking beta blockers. Okay. Now, the ACE inhibitors, of course, it should be avoided completely in pregnancy, as well as the ARBs, and it is preferred in patients with diabetes, chronic kidney disease, and heart disease. Beta blockers preferred in patients with like heart failure and in patients with angina, but it might make the asthma and the COPD worse, and it might make the glucose intolerance also worse. The other medications that we have, of course, the aldosterone antagonists, the loop diuretics that I mentioned, the alpha blockers, and other medications. Now, what about timing of blood pressure medication? Is it, better to give it at night or in the morning? I mean, this Hygia study, which was published last year, actually a year ago, showed that really giving the medications at bedtime will improve the cardiovascular outcome. And all the outcome was improved compared to giving it in the morning. The total composite endpoint, the stroke, the coronary events, the cardiac events, all improved with giving the medications at bedtime. For me, if a patient is on more than one medication, really, I advise them to take, the medications, some of them at night and some of them in the morning. If they are on one medication, I started to recommend to use it at night time. And in the Canadian guidelines, they recommended the thiazide-like diuretics rather than the thiazide because they are more effective and the studies are more on their behalf, like the chlorphalidone. And also the single pill combination now, as we will see in many other guidelines also, it is considered as first-line treatment. So in the beginning, from the very beginning, especially in like grade 2 hypertension, we start with single pill combination rather than starting with one medication and raise it to the maximum and starting another medication. We may start with low dose dual or single pill medication in patients with not very high hypertension, but it is more convenient and it is one pill with like two medications, as we will see. It is, as I mentioned, evidence-based, and it is more like convenience. And many studies showed that single pill combination is very effective, and it improves the outcome, like the HOPE-3 trial and the ACCOMPLISH trial. So now the first-line treatment, according to Canadian guidelines, and this is like 3 years ago, they are not only including the thiazide diuretics, the ACE inhibitors, the ARBs, the long-acting calcium channel blockers, and they are still considering beta blockers for the Canadians, contrary to the American, but they are also mentioning single pill combination as first-line treatments. And the single pill could be combination of ACE inhibitors and calcium channel blocker, ACE inhibitor and like diuretics, or like ARB and calcium channel blocker. Of course, we don't combine calcium channel blocker with ARB. It is contraindicated to combine those two medications. Now, in some certain like Populations like in diabetes, we of course prepare ACE inhibitors or ARBs, and this is the American guidelines and the other guidelines of course, and it should be considered especially if the patient has albuminuria. In patients with chronic kidney disease, especially with high albuminuria, of course we consider ACE inhibitor as first line. If not tolerated, then ARB. For patients with stable ischemic heart disease, for example, it is preferred to start them on beta blocker or ACE inhibitor or ARB. And we might add, if the patient has angina, we might add the dihydropyridine calcium channel blocker. Now, if the patient has low ejection fraction, non-dihydropyridine calcium channel blockers are not recommended actually in those patients because they might make the heart failure worse. But if the patient has heart failure with preserved ejection fraction, then we might consider actually after management of volume overload, we can use ACE inhibitors or ARBs and beta blockers. Patients with atrial fibrillation do better with ARB, and this is based on evidence. So this is what we mean by the presence of compelling indication. It is, we choose the medication according to the patient and their comorbidities. Now, in older patients, according to the American Heart Association, we have actually to balance. If the patient is very fit and they don't have like many risk factors and their like really life expectancy is high, then we aim at reaching the same target, less than 130/80, and treating the other comorbidities. If a patient has like limited life expectancies and many comorbidities and they are frail, then probably we are more relaxed and we don't like aim at the same target. We have to use our clinical judgment really in choosing. Patients who are pregnant, of course, the treatments which we use are methyldopa-nifedipine, labetalol, and we should completely avoid ACE inhibitors or ARB. Now, actually, there is the new concepts in hypertension which we should utilize in this era of like information, which is transforming the treatment of hypertension, and we see it now with the COVID, as we heard from Dr. Al-Bassam, epidemic and the need for remote hypertension treatment, and they need to utilize more and more technology, including the home-based blood pressure, and using this and transmitting it electronically, and also using the artificial intelligence and utilizing more and more like new technologies in our treatment. In the COVID-19, I'm sure Dr. Al-Bassam talked about this. You should not stop ACE and ARB if the patient is on those medications and stable on this. The last two things that I'm going to mention is the most recent guidelines. Actually, they are the NICE guidelines in 2019 and the International Society of Hypertension guidelines in 2020. All of them, they actually talk about the same concept, the use and the utilization of out-of-office blood pressure measurements to confirm the blood pressure and the hypertension definition, and they slightly differ in the target, but most of them now they are going more aggressive with less than 135/85 or less than 130/80 as a target, especially for patients with many risk factors. Of course, the NICE guidelines always differentiate depending on the age. If the patient is less than 55, then it is preferred to use ACE or ARB as first line. If the patient is more than 55 or African American, then it is preferred to use calcium channel blocker because they respond better to those treatments. And then you add any other medication from the first line treatment. If not really reaching the target, then you consider the other medications like the spironolactone. The International Society of Hypertension, actually, they are talking about essential and optimal treatment. The optimal treatment for those who are less than 65 is really to reach the target of less than 130/80, and the essential is to decrease the blood pressure at least by 20/10 millimeters mercury. And it depends on the grade, as we mentioned in the beginning of the hypertension. You either start with immediate drug treatment or you give some chance for lifestyle changes, especially if the availability of the drug is less and if the risk factors are not like the patient does not have a very a lot of risk factors, and then you go by steps. The European or the international are also agreeing with the Canadian that you should start with really single pill combination or with dual medication or combination, but you start with low dose from either ACE or ARB with calcium channel blocker, or you start, if the patient blood pressure is high, with dual full dose with the same combination, and you add, D, which is the thiazide diuretic, to this combination if you are not reaching the treatment, and finally you add the spironolactone or other medications if you are reaching the resistant hypertension. So in summary, reaching the target is the most important. We start with lifestyle. It depends on the number of the risk factors. It depends on the patient and individualization of the patient, the presence of comorbidities, and also the degree of the hypertension, and also the presence of end organ damage in deciding how aggressive and also how fast we should start treatment. Thank you very much. This was my last slide.
Thank you very much, Dr. Hussam, for your comprehensive review. Announcement for the audience: please fill the feedback which was sent in the chat, so that we can improve our future webinars. Now let's take some questions. Let's start with Dr. Tawfiq. What is the prevalence of hypertension in Saudi Arabia? And the one who asked this question is looking for a reference also. Dr. Tawfiq,
Yes.
please. Okay.
Do you hear me now?
Yeah.
Yes, okay. Now, the prevalence in Saudi Arabia really varies depending on the study, depending on the site done, and so on. It varies between 20 and 21%, some studies 27%, and so on. So taken together, you need to refer to which study you are using and point out to the result of that study and pick up the number. But generally speaking, 25%, 27%, 29% is relatively acceptable depending on the study.
Thank you very much, Dr. Tawfiq. Dr. Abdul Hamid, if the patient cannot offer blood pressure monitoring device, so how can we accurately monitor his medication and blood pressure control?
Thank you. Very important point, and it was dealt with in the International Society of Hypertension basic recommendation that we will depend on the frequent measurements in the clinic. But the best is a machine for every patient with hypertension. And this is approved now by Majlis al-Daman al-Sahi. All insurance companies will offer a machine to all patients with hypertension, exactly like the glucometer. But we hope it will be suitable for every person.
Thank you, Dr. Abdul Hamid. Dr. Hussam, I think you, by mistake, you mentioned that calcium channel blocker are contraindicated with ARBs. What I think you mean ACE inhibitors with ARBs are contraindicated. Is that correct or not?
Yeah, of course. ACE inhibitors and ARBs, they have the same mechanism of action. It should be avoided as combination. But calcium channel blockers and ARBs or calcium channel blockers or ACE inhibitors, of course, are found in many combinations, and they are actually the base for many single pill combinations. Thank you for correcting me.
Okay. So the question to you, Dr. Hussam, what is the best time of antihypertensive medications? You mentioned that if the patient is taking more than one medication, one of them, it is better to be kept at night. But what about each class of medication? Should it be taken in the morning, in the evening? Which class do you prefer to keep it at night? Is it with food or on empty stomach? Can you elaborate more on that regard?
I mean, in general, I mean, now there are more and more like really evidence regarding bedtime treatment for all kinds of medications. But generally speaking, I would like to avoid the diuretics-based regimen in the evening, so the patient will not wake up. I prefer to give it in the morning, actually. The long-acting medications, I mean, it doesn't matter really whether it's like really after food or on empty stomach. The bedtime means most likely it's on empty stomach. So we go by just and the evidence is evolving in that regard. So in general, I like to avoid the diuretics at night time. I prefer to give it in the morning. but now the evidence more and more is toward using the bedtime regimen, if possible, actually, for most of the medications.
Okay, thank you very much. Dr. Tawfiq, going back to you again. Is there a relationship between exposure to pollution and high blood pressure?
Yeah, I think for the last 5-6 years, there is an evidence shows there is a relationship. It seems that the air pollution, especially particulate, which are about 2.5 microgram in size and very, very small size, they are able to go and inhaled, and you just sit in the alveoli, causing inflammation and destruction, fibrosis. And then it seems that they're able to leak through the damage to the circulation and deposit it in the vessels, in the kidneys, and this will sort of start hypertension or high blood pressure process. In a sense, this is all recent evidence. We're still waiting for more evidence to support this theory. If it turns out to be true, then probably we need to advise our patient, in addition, to be careful of staying in an air polluted area a long time, because that might be bad for their blood pressure if they are hypertension. But as I said, we need to wait for more evidence to support that management plan.
Thank you, Dr. Tawfiq. Dr. Abdul Hamid, is it a recommendation for decision makers and for patients to supply validated blood pressure devices for free for the community? I'm not talking about those patients who have insurance. I'm talking about, for example, patients who are coming for MOH primary care centers. Do you recommend really to supply validated blood pressure devices or not? And another question. What do you expect the consequences of doing out of office blood pressure measurement on the prevalence of hypertension? Do you expect to have more hypertensive patients or less, or there is no change? Dr. Abdul Hamid.
Thank you very much. Very good two questions. The first question, I recommend that every patient with hypertension should have a machine. From where? It is the community to decide. It is the authority to decide. Exactly in diabetes center, in MOH, we provide glucometer for all patients with diabetes. So again, in the MOH, we should provide a blood pressure monitoring machine to every patient diagnosed with hypertension. This should be. And once there is privatizations and the insurance that will cover the whole kingdom, the insurance companies will be covering all patients, providing all patients with a machine. Regarding if the outcome, it will not increase or decrease. It will give us the real prevalence of hypertension, whether it is very high or very low, whether it is the same. It will give us, because the title of my presentation is the identification. We don't identify really who is hypertensive or masked hypertension or white coat hypertension, white coat effect. This, we are in a mess. That's why we should go to the confirmation, like exactly as you are going to test random blood sugar for every person and it is 200. You don't know whether he is diabetic or not diabetic. You need to go for confirmatory test. So the confirmatory test of hypertension, to diagnose hypertension, to know the prevalence, it is out of the office blood pressure measurement. Thank you.
Dr. Hussam, is there salt in the market containing potassium instead of sodium can be used for cooking?
I'm not sure about the taste though, but I mean the potassium is more like found in I mean the green leaves, and that's I mean the advocates and the other like fruit that we mentioned actually. But the salt, I'm not sure about the taste if it's available.
Okay. Another question. When should we start loop diuretic as first-line treatment?
I mean, the diuretics is especially the thiazide-like diuretics now, or the thiazide itself is first-line treatment. you can use it in any patient really. But I mean, it is more like indicated in the patients that we mentioned, like the patients who have congestive heart failure. And if the patient has some contraindication like gout or like very high dyslipidemia or hypercalcemia, it should be really avoided. But it should be considered. And it is more preferred in patients who are older rather than who are younger. Like according to the NICE, it's better to use it in patients less than 55 years of old to start with ACE inhibitor or ARB rather than thiazide or calcium channel blocker. But it is first-line treatment. You can use it in any patient unless there is contraindication, really.
Thank you. Last question for each speaker. Dr. Tawfiq, can you elaborate more on the titration of antihypertensive? Should it be every 2 weeks, every month, every 2 months? So how to titrate antihypertensive medication?
Yeah, I think this is an important question, an important point to realize. I think the sooner the better. For example, if you can do it every 4 weeks, 6 weeks, yes, that is the best time to follow up and then decide to titrate or not. But in real life, actually, in most of us in the clinic, the patient, you cannot afford the patient come in 4, 6 weeks. You have too many patients on the clinic. It's going to take you about maybe 2 months, 2.5 months before you see him again. But the best answer for your question, I'd rather to see him every 4 weeks, maximum 6 weeks to see him again and decide does he need titration or continue the same medication or switching to other drugs depending on the response of that patient. Thank you.
Dr. Abdul Hamid, is there evidence that home monitoring of blood pressure affect the control of blood pressure or affect morbidity or mortality?
Yes, the last paper I presented, the position statement from the American Heart Association and the American Society of Medicine, they said that there's evidence for home blood pressure monitoring to improve adherence and control. That's why they recommended this in 2020, that home blood pressure monitoring is very important and is recommended for all patients with hypertension. I went through quickly the paper, but it is an official position statement for the American Heart Association recommending home blood pressure monitoring because it is cost effective and it is efficacious in improving the control of hypertension.
Dr. Hussam, is there evidence regarding Carcadet?
I mean, I see it work in my patients. I'm not sure about the strength of the evidence. Maybe my colleagues will help me in that. But I see it work. But I mean, there are more evidence regarding other like kind of juice, like the rumman, permanganate like juice. There are some more evidence regarding other medications. But the Carcadet, I'm not sure about the evidence, but I see it work in some patients really. I don't know if my colleagues have an answer also for this, because it's from clinical practice. But I would like to go back to the question of the diuretics, because I saw follow up a question actually from the same person, I think, attendee. The question about the loop diuretics. The loop diuretics are not first-line treatment really, but if the patient has like congestive heart failure, they are part of the regimen and they can be used from the beginning among other medications. If the question is regarding the loop, okay? Mm-hmm. Yeah. So for the Carcadet, I don't know if Dr. Bassam or Dr. Hamid Hassan have really more to elaborate on that.
For myself, Dr. Hussam, really, just as you said, the evidence, I can't remember it, I can't trace it now, but as a rule, if the patient feels better and improves, my theory is always go for it, if there is no harm. But I don't remember the evidence to justify to say it just now.
Thank you. 2 points. Carcadet will be taken with the sugar, and this will increase the problem of obesity and diabetes. The number 2, that many patients are saying the cold Carcadet is hypotensive and the hot Carcadet is hypertensive, or the vice versa. So I don't use it whatsoever with sugar, without sugar, cold or hot. No use for this. I don't recommend it at all. Thank you.
Okay. At the end of this webinar, I would like to thank all the speakers for their excellent reviews. I would like also to thank my colleagues at the backstage, Dr. Badr and Mr. Hassan Mdefa. And I would like to thank you all for sitting with us till the last minute. Thank you very much. And see you in future webinars.
Thank
you. Thank you again, Dr. Badr, all the colleagues for this hard work.
Jazakumullah khair. Thank you very much.
Thank you very much.